that prosthesis out without really hurting the patient. And for somebody who has done both, trying to cut crowns and trying to get a cement retained prosthesis out, and for somebody who has done a screw retained prosthesis like this and taking it out once every year or once every 2 years, I know that it's very easy to maintain these kind of prosthesis over a period of time. Also gets much more when you have more degree of resorption. See, these kind of cases where you have adequate amount of bone and your implant to tooth interface is much more coronal, it's a lot easier to maintain. But when you have this kind of a resorption, which is where the basal implant philosophy is all about, it's not for bone where you have adequate amount of bone. It's for cases where there is no bone, where we have so-called given up. Yeah, that's where the basal implants fits in. But when you have that kind of degree of resorption and you have to place your prosthesis all the way up over there, what is the kind of maintenance that is possible in patients like this? And that's the reason why in conventional dentistry, we know that elderly patients, geriatric patients who are not able to maintain hygiene no matter what you do, even though there's a possibility of giving a fixed restoration to these patients, we are able to give them overdentures. We are able to give them dentures which they can take out, clean outside, clean the bars inside the mouth and try and maintain hygiene. Even if they can't do it, the caretakers can do it. And I think this is a very important aspect of restoring teeth, especially for geriatric patients. Yeah, the kind of resorption that can take place where you have your tooth over here and you have your implants placed over there, the kind of an vertical and horizontal cantilever that you're going to get on that prosthesis is almost impossible to maintain when something is fixed like this. Dr. Kumar, do I have time to continue, or you want me to break and continue later?
Break will be better because then we get other perspective as well.
That's right. So then it could be this, because from here on, I was going to talk about the various possibilities of doing conventional work. I'll always come back later and make that point. Yeah? Thanks so much.
You know, it's a tough job as a moderator. And if you ask me who asked for it, I think I did, so I can't complain. Having said that,
sir, imagine, sir, could you?
Sorry. Okay, yeah. So slide by slide, you want to answer. Okay, okay. So is Professor IHDE coming, or you are answering? IHDE, okay, good.
Sir.
Now, there were some questions raised on various issues. And this is where I need to step in as a moderator. A few of those questions, maybe quite a few, are also relevant for conventional approach in implants. People who are following conventional approach, haven't you all perforated? Answer is, yes, you have. Have you erred on the angulation of placement? Yes, you have. Did you have a problem in making impressions on divergent implants? Yes, you had. Did you have a problem with food getting stuck in a well-planned prosthesis? Yes, you had. Was that a challenge for your patient? Yes. But we are talking about the predictability. And that is where a few of his questions were directed, and of course, rightfully addressed by members of the audience, that we do have answers. Sure, we have answers. The request that I have to make here is, allow all the speakers to finish their piece. We have rebuttals, as Professor IHDE is ready to answer all of those one by one. We also have a panel discussion involving the audience for the questions related to the issues spoken and to the issues not spoken and not shared. This platform, like I showed you in the morning, is there to help you to go back with answers, with scientific answers. And that is where I thought that before he went on to address the conventional aspect, there are some answers which we will now seek. And Professor IHDE says, slide by slide, you would like to answer and rebut those queries, correct? Professor.
Before, yes.
We are having a little bit of jig of the schedule, as you would see, as we had originally planned, and we are completely open to rejig it I only request the speakers to bear with us with the rejigged schedule. Yeah.
I just request, I just request a minute from Dr. Ide to make a few announcements. There were some concerns about the screen which goes right down up to the floor that people at the back can't see, so we've changed the configuration as much as we can. I hope it helps you. Otherwise, you're welcome to come and sit in the front rows which are empty. The second we would like to make is that we saw that a lot of people from the audience are interested in making pictures out of the slides. I have approached the speakers, and most of them thankfully have agreed. So let's give them a round of applause that, they don't mind sharing their work. Thank you so much. And I believe Dr. Ide has introduced himself.
Yes, sure.
Yes, so I'll let him take the stage. Thank you so much.
So thank you very much. The first time in my life I give the lecture on somebody else's slides completely, but I think it's the easiest to do that. Now, I don't see here this slide where these cars are driving in the wrong direction. One more? Here we go. Well, I don't think that we are driving in the wrong direction. I think the thing is, you think we're driving the wrong direction, but in fact, we are already arrived before you have started. I'm sorry to say this. Okay, but let's come to the unanswered question, and I try to give you a few answers. Surgery, prosthetics, just a moment. Is the concept of lingual cortical engagement and perforation experimental? Well, I do this for many years. We all do this for many years. It's the general strategy in traumatology to use two corticals and to go with the fixation screw through the first cortical with or without engaging into the first cortical, and then to engage this device into the second cortical. This is the principle of traumatology. This is what we are doing. The question whether we will perforate there or whether we will, just allow the engagement of the implant, I never asked myself this question, to be honest. You're the first one to ask this question. For me, it's the safest if I take the drill and just perforate, and then I know that I can really screw the screw in, and it's fixated in the second cortical. Is the concept of double pterygoid implant experimental? Yeah, what do you mean by experimental? I mean, anyway, we have to engage the implant into the pterygoid plate of the sphenoid bone. This was described, as far as I know, the first time in 1992. To Lassner was, I think, the first one. So this is a part of our work in our profession. I mean, you can calculate yourself. It's about 25 years this is done, so it's not experimental or new. I mean, simply it's done. And if you put double tubular pterygoid or triple tubular pterygoid, well, if you have enough bone, if you know where the bone is, if you do this either in a guided procedure, or simply you know where the bone is, or sometimes you can just palpate it. I mean, there can be a strong resorption of the maxilla, and then this sphenoid bone is in front of you, so I see no problem to screw into it, because I can see it, so I don't think that this is experimental. It is actually very simple. Is there any scientific data on it other than mentioned in a book? Well, yes, of course. Just read the literature, and if you give me your card, I will send you a lot of literature, also my articles, also statistics about tubular pterygoid screws, engagement into sphenoid bone. I don't think that anybody discusses this today, to be very honest. You're the first one who doubts this.
Can you hear, or I just keep quiet now? Okay.
Oh, I will send you the articles,
because this will. Okay. Okay.
Mm-hmm. Yeah, I just go through this, because there are so many questions. Now, here, in this case, It's not. It doesn't work on these screens.
No, the pointer doesn't work.
Sorry. So in this case, on the picture, the lower right side, you see an attempted bypass. So there are different possibilities to place implants in a distal mandible. So first of all, if you have enough bone on top of the nerve, then anyway, no problem. We can put two-stage, you put compression screw, whatever you put. The second is you don't have enough space, let's say no 10 millimeters or whatever you think is enough. Then you can, of course, attempt to bypass the nerve. So now here's the nerve, and then you make a CT, and you decide, okay, I go here or I go here. So this is the normal nerve bypass. I think this is described. You can do this with a compression screw, as shown here. I mean, all these conical screws are considered compression screws. You can do it maybe also with, I don't know, Biohorizon, Straumann, whatever, if there is enough bone width. Now, the other point, of course, the other thing that you can do is you can use, you can use the second cortical for lingual cortical engagement. Sorry, I have to do this again. I went in the wrong direction. How can you avoid injury to the inferior alveolar nerve during the bypass? Well, the bypass is not really the strategic implantology procedure. Basically, the bypass has nothing to do with us. We don't bypass. You know? We engage in the second cortical. And the second cortical, this is usually this overhang on the lingual side. Or we use the vestibular cortical. But I would say 100% of these implants are way on top of the nerve, or they are outside of the mandible. I come to this. Huh? So this is not strategic implantology, this procedure. It's an attempted bypass, or probably a failed bypass. Now you were raising question, how can you ensure that you don't hit a bleeder during the intentional lingual cortical? Well, this lingual cortical perforation is done behind the number 4, okay? 5, 6, 7, 8, okay? And according to my knowledge of anatomy, there is no artery there. I mean, you would shock me if you prove that there is an artery that could create a bleeding. I agree with you. Between 4 and 4, you have the sublingual arterial anastomosis, and of course, nobody would want to drill out there. But distally to that, you know, this is the first time I hear that there's a vessel. And I mean, look yourself. You have a nice picture here. I mean, just show me I mean, the facial vein down there. But this is far away. I mean, then we are not talking about lingual cortical engagement. And this implant must be 2 centimeters too long. And there's no engagement anymore. But so what you can hit, of course, is the submandibular gland. And as you probably know yourself, it is impossible to drill with a drill, which you use for making osteotomy in implantology, to drill into a gland unless you trap it somewhere. I mean, you hold it, and you simply this gland, all the nerves, they escape. You cannot drill into it. It's not possible. So that's why I have never seen myself, and I have never heard about any injuries of this gland. And as you can see on your own picture, there is nothing. I mean, I'm not saying that you should drill out here into this region or to drill into the tongue. I don't think anybody does this, and you can for sure avoid this. But if you just drill if you just drill out of the mandible, then you can do this. Huh? The facial artery, it's on the other side. We're talking about lingual cortical. You know what is lingual? This is on the there. Huh? The facial artery is here. No. I mean, look, we are talking about this drilling from here to here, and all you have there is the gland. There is nothing else. Trust me. I mean, all my books, all my life, everything. I mean, I've never seen anything else than the gland there. So let's come to the next one. Okay, these are nice pictures, but I think it takes too long to explain what you see there. Then you are worried, how can one be sure that the tracheal plates have been engaged during the implant placement? Well, I'm sure that I engaged them because I feel it. You know, suddenly it gets like 80 Newton centimeter, and this tells me there must be some mineralized bone. And from my imagination of how this anatomy is, and from what I learned in the anatomy courses, I'm sure it's the plate, you know, there's nothing else. It can only be there. So the plates have been engaged with implant plate. Of course, you can do this in a guided procedure, also possible, no problem. How can bleeding be managed if a vessel is, yeah, which vessel? Again, the same question.
Probably in the panel discussion. That will help us to come back on time. Yeah? No, we come back with all the slides. The same slides will come back, and he can rebut on that. The reason, you must understand that we are really lagging on time. So please try to respect that. I request you. Yeah? Because he's come point by point beautifully. All I'm saying is, he has his presentation, and he further have panel discussions. And there are at least 4 more speakers.
Yeah.
That's the reason.
Well, maybe we skip my presentation.
You're ready to skip your presentation?
Yeah.
Oh, then please go ahead. Then please go ahead.
You know, I mean,
Absolutely.
I mean,
Yeah,
better
actually, I feel that this is better because the way you have gone about explaining, so probably in your presentation, you can probably condense it and use less time. That's fine with me.
Okay.
All in the interest of
if I
keeping
can
up
continue,
time. That's okay.
I mean,
Yeah.
okay, so let's come back to this. Where was the next question? Master said this. How can the preparation be done? Yeah, either the dentist technician gives us little jigs which allow us to shorten the heads vertically or to shorten it from the side. Actually, there are a number of reasons why we would shorten these heads or why we would grind them. This is, of course, the missing parallelity. Then a problem in aesthetic that this implant simply is too far out, so we have to grind it back. And the third problem, which we address by grinding, is problems with phonetics. Because also, if the implant is too far in, then there can be a problem, and all this must be done. But from these 3 examples, you see that it is very important to train the dentist technician. Because a dentist technician, if he has this thing in the articulator, he will understand, okay, this implant is too high, I have to shorten it. But we also have to train him to see from the analysis that there will be an aesthetic problem and there will be a phonetic problem if he doesn't do anything against it. So this, as I said, it requires lots of training. So we don't have to be so exact. I mean, I'm using Fuji Plus cement. If you work with screw-on bridges, like a multi-unit head on the strategic implant, then anyway you have no problem. I think you know how this is done. So the frame is done. There's a T-base inside. The T-base is glued to the frame after the frame is ready, maybe in the mouth or on the model. So there's no tension possible. It's absolutely passive. You can just screw it in and out as often as you like. So this is how it's done in the screw world. I mean, in this multi-unit world. And but nevertheless, I prefer to cement. If a jig is made of pattern resin, I don't understand the question. As I said, we usually, if I have doubts with my bite taking, I use the Gothic arch device. You know, this pin. No? Doesn't the jig make pattern resin keep cracking up while taking it first? Sorry, this question also I don't understand. Casting made over such a model can never fit accurately over the implant. Well, it fits, of course. You see, it doesn't matter if the implants are, or the heads of the implants are not parallel. The frame must be made so that it fits when it's down. The question is how we get it down in the mouth. There's another, you know, but these basal implants, these strategic implants, they have some elasticity. You see, the implant is fixated in the second cortical. Sometimes the implant is 26, 29 millimeters. So this implant moves. No, it's not osseointegrated yet. It will osseointegrate it. And I'm not talking about the difficulties when you do the second bridge after 3 years, because then everything along is integrated. It's not only osseo-fixated in the second cortical. It's really rigid. And for doing the second bridge, we very often have to bend more, because it's impossible to get the bridge in after this implant has become rigidly osseo-integrated. So for the first bridge, usually we don't have this problem, because this implant is fixated somewhere up there in the second cortical, and we can just get this bridge in. It takes experience. You have to see this really with your eyes to believe it. I understand nobody from the two-stage world believes it. It takes time to make the dentist technician believe that this bridge can go down, because the normal dentist technician, when he sees these non-parallel analogs. He will give it back to you. He said, come on, you're crazy. I'm not going to do this. This will never get in. But you have to train the dentist technician to tell him, look, you give me this thing passive here, however you do it. I mean, he can cut the model, you know, to make these double models. Then he gets it passive. And if it's passive, I will get it in. This is my problem. If it's passive on the model, I will pay him. Is the casting usually too passive or too active? Well, you see, these implants are not integrated, and I mean, how to say this? The implant, if it's a little bit under the pressure, then it integrates a little bit in this position. And I never saw an implant complaining about this. Simply, it's, you know, the implant doesn't care. I mean, it doesn't matter. For the two-stage is, of course, a problem that if your bridge is, like you say, active, or if it's creating tangents on the implants, then you start getting bone loss. But we don't get this bone loss because the bone loss is in the first cortical, and we don't get this bone loss because we don't engage in the first cortical, and we have nothing to do with the first cortical. If a patient has the first cortical, he doesn't have the first cortical, I don't care. As long as I see a thin white line on the panoramic picture, this is the floor of the nose, I'm happy. I don't need to see more. I don't need more bone. It takes a lot of time to drill these long holes. It's much faster to treat a patient with a strong atrophy. It's perfect. Do these castings have to be forced? Have to be forced or to mallet it in? Well, we just put it in and cement it. Huh? Yeah. If not, then the casting ought to be loose. Yeah, you see, if there are 8 or 10 implants in a circular bridge, this frame is never loose. I mean, there you have to take really out a lot. I mean, we are not talking about this sombrero type of crowns. The crowns should have some fit. Yeah, I mean, you see, even if I cement this bridge we use Fuji Plus, and so I put it in, and immediately I wash out all the cement under the bridge, immediately, within the next few seconds, because it's not so easy to get the cement out later. And of course, if the bridges, the crowns are sombreros, then the water would get in and the cement would come out. So there has to be some fit, I would say. But it's not, I mean, we are not talking about academic fit. We talk about practical fit. No? Are there overhangs around the margins of the abutments? Well, in the vestibular side, of course. Yeah? And anyway, we have to do very often overhangs on the vestibular side because we need to support the soft tissue. I mean, you showed a case there. In this case, I will come to this. It was not necessary to create an overhang because the alveolar bone was white. There was no resorption. It was a little bit vertical resorption, so the bridge more or less kind of continued with the alveolar bone. But this is unfortunately not the case that we have. I mean, there's either no alveolar bone or there's a knife edge ridge. The implants are even on the palatal side. And this is, I mean, we are talking about different cases. Huh? Okay, how's the occlusion adjusted? Well, the occlusion we adjust with the cusps and fossae. I don't understand the question. I mean, how is the occlusion adjusted? We use cusps and fossae. Okay. How is the cuspal anatomy? You see, in general, in life, in the normal, Dr. Lucas will talk about this. In the normal course of life, we all get abraded, not only here, but also here on the tip. So if we have only teeth, I mean, without like gold inlays, zirconium crown, and so on, in the course of life, we all have abrasion, which means the IFMP angle gets more and more and more flat in life. And if we only live long enough, then we're all going to have a horizontal 180 degrees. This is for the normal patient without implants, like the Aborigines in Australia. They show this type of development. And depending on the age of the patient, we are also moving him in this direction. Yeah. And I think this is justified because this is the normal way of life. It is not normal to have long vestibular cusps in a person which is 50. I think it's wrong to do this. And this is not what the patient expects. And you know probably yourself that those teeth who are suddenly equipped with such crowns, with such large vestibular cusps, which look nice, of course, in the textbooks and in the journals, but this patient is going to run into a periodontal disease and into mobility of the teeth. That's why we grind these cusps away. So I don't think we need specific cuspal anatomy. The 0 degree setups. You see, basically, if you have 0 degrees, if you do from the beginning this horizontal, then the mandible can move freely, and there's never any danger that from the mastication the implants are mobilized. Because we are working in immediate loading, and we work with very little bone, so we have to protect our work a little bit. If you feel that you later on want to equip this patient with more cusps, longer cusps, then you just give him a second bridge. Or if the patient complains, the amazing stories. I mean, you can go with the heatless over this thing, and then you're engraving a few fissures, and the patient can eat. This is most amazing. Nobody complains that he doesn't have any cusps. Why is there always an open bite in the prosthetics? Yeah, we don't have open bite. We don't have front contacts. That's all. Because the implants are setting a polygon, and we don't want any forces outside the polygon in the front. Especially because we know, and simply this you have to believe now, that if you give the front teeth the possibility to touch, then you are creating an anterior pattern of chewing. So this is the wrong pattern of chewing. We want our patients to have a lateral pattern of chewing. We think this is normal. Oh, it's like walking like this. This is, I think, normal. It's also possible to walk like this. But this is not what we want. So we don't want to give to the patient an anterior pattern of chewing. And as soon as we give them front teeth contacts in occlusion, there is the danger that this happens. That's why we don't want to do this. It's a functional question. Cannot be cleaned easily. To tell you the truth, from my implant patients, we don't give them instructions to clean. We don't expect them to clean. We don't mention anything about cleaning. We only tell them, if you should be interested to clean your teeth, I mean your bridge on the implants, don't use toothpaste. Simply this is. Because this toothpaste is a real problem. All these little particles, they can go into the gaps. They can roughen our polished implants if they should be exposed after years or whenever. So in general, the patient who has no teeth at 40 or 45 or 50, he is not in the group of the cleaners. He's in the group of the non-cleaners. That's why he has no teeth. And I don't think that I can re-educate this guy. I don't even try. I simply give him a workpiece and implants where he can stay as he is. I also wouldn't try to cure the alcoholic. I wouldn't try to talk to the smoker not to smoke anymore. And I simply assume that our patients are non-cleaners. So I give them something that they don't have to clean. It's true that there can be some food be retented. Sometimes the patient comes and complains, oh, if I eat the piece, then here's the piece. So what I do, I make this gap bigger. So it doesn't go in, it can also go out. And this usually solves the problem. So the method of maintaining hygiene, I don't know, I don't know how the patient maintains hygiene. He hasn't done this before. He will not do it in the future, I'm sure. Cases of severe resorption prosthesis abutment interface is deep down in the vestibule. This is true. I mean, of course, the higher this denture is, the more is down. And this is indeed, and I will just show you only one case from my computer where one reason why we sometimes don't give fixed bridges, we give bar and denture. I completely agree with you that the fixed bridge is not the standard solution for severely atrophic cases. So I think that's it. And I want to show you only one case that you...
IHDE,
Yeah.
one question that I had, would you address it, please?
Yeah.
Being a periodontist, the soft tissue interface with the prosthesis is always a challenge. So in this design and planning of implants of your philosophy, Basil, in your experience, have you experienced recession or have you experienced a soft tissue overgrowth or none at all?
You mean on the prosthesis?
Over a period of time?
On the prosthesis.
Away from the prosthesis or over the prosthesis, depending upon whether it's a shrinkage or it's a
Or
growth.
if we extract and if we don't create atrophy by reducing the bone and the soft tissue, then of course we will see atrophy. I mean, we just extract and we put the teeth in the same place like before, then of course we will see gaps, and then we have to renew the bridges, of course. The second part of the answer is it depends on the material. If you're using full zirconium bridges, for example, on these implants, then this material seems to be so biocompatible that I mean, this is my experience, that it kind of sucks more, and it keeps the contact to the soft tissue. You don't see this on metal acrylic bridges. You see it more on ceramic bridges than on metal acrylic, but the best material, of course, from a soft tissue point of view is